dear chair, dear colleagues, allow me to present my PhD thesis, which is the prevention of breast cancer surgery complications. After mastectomies performed due to breast cancer, seroma formation rates can be surprisingly high, in cases up to 85%. Unfortunately, many strategies have been tried, such as quilting sutures or tranexamic acid, but still there is no gold standard for a prevention method. What if I were to tell you that with a single injection you could halve these seroma formation rates? Based on our meta-analysis of 13 articles, we have found that perioperative glucocorticoid treatment can be very effective, resulting in 40% less seroma formation rates. Thus, clinicians should consider and add the glucocorticoid treatment when performing mastectomies. I'm Levente Doleviczényi, a general surgical resident at the Department of Surgery, Transplantation and Gastroenterology, and I'm also a first-year PhD student. Our vision is an improved post-operative quality of life in women with breast cancer, and in order to achieve this, we want to assess the different available surgical techniques and strategies. We have two ongoing projects, both of which have started in the autumn of 2024. First one is the significance of perioperative glucocorticoids in the prevention of seroma formation after mastectomies, and the second one is focusing on the latissimus dorsi muscle harvest and its complications of the donor site. Let's focus and start with the first one. So, as for the background, breast cancer is one of the most common cancer in women, with over 2 million new cases diagnosed worldwide in 2022 alone. Surgery is still a main pillar of the multidisciplinary treatment. After mastectomies, seroma formation is the most common complication that can occur in up to 85% of the cases. You could ask yourself, what is a seroma? Well, it's a palpable accumulation of serosus inflammatory fluid in the operative area, and this can lead to repeated aspirations. It poses a risk of infection and can even delay oncologic treatment. Thus, dealing with seromas is critical for optimal patient care. We have already spoken about the many strategies tried. In this project, we are focusing on glucocorticoid, which is either methylprednisolone or hydrocortisone, as the prevention method. Our aim is to determine whether using perioperative steroids are beneficial for our patients. With our clinical question, we have used the PICO framework. And the question is, in patients undergoing mastectomies, does glucocorticoid use decrease the development rate of seromas compared to no drug use? Our hypothesis that these perioperative steroids are beneficial and decreases the rate of complications. With the clinical implication, we want to contribute to guidelines and perioperative care of mastectomies. Here you can see the search key with consisting of two domains. First one focuses on mastectomies, and the second one focuses on the glucocorticoids. We have searched in 5 databases. You can see the hits below. Here's the flowchart selection. We have started from well over 7,000 articles, and we have included 13 articles. 12 of them are randomized controlled trials. Let me present the most important figure, which is, of course, the seroma formation rate. It includes 9 randomized controlled trials with over 800 patients. You can see the columns, glucocorticoid and the control groups. And the heterogeneity was moderate. This can be due to the different doses, the different timing of the glucocorticoids, and even the different type of steroids, such as hydrocortisone or methylprednisolone. We have expressed the result in risk ratios, which was 0.56, which means that in those patients that got glucocorticoid treatment, seroma formations were more than 40% less likely to occur, which is clinically highly significant, as it's almost halves the seroma formation rates. This is also was a statistically significant result, and even the subgroup differences were significant. Another important figure, which is wound infection rate, because of course steroids could have adverse effects. So we wanted to examine the wound infection rates as well. This is with 6 RCTs. We divided the subgroups with preoperative and postoperative steroid treatment with over 500 patients, and the risk ratio was 1.26, meaning that in the glucocorticoid groups, wound infection rates were higher than in the control groups, but this hasn't reached statistical significance, but the tendency was clear, and we have to be careful in the future because of this. So our conclusion is that the perioperative glucocorticoids are highly effective in reducing seroma formation rates in patients undergoing mastectomies. The implication for practice is surgeons should use or consider perioperative glucocorticoids when performing mastectomies. The implication for further research is that we must study the safety and the wound infection rates, whether these are truly correlate with the glucocorticoids, and whether these complications can be tackled with with antibiotics use. And also we have to check whether the direct comparisons between the different doses, different timings, preoperative, postoperative, or even the drugs such as methylprednisolone versus hydrocortisone. Our strengths that our analysis is comprehensive and conclusive. We have examined several outcomes with subgroups, and also our main outcomes are of randomized controlled trials only, which presents a high level of evidence. A limitation is that there is a high risk of bias in some studies, and also the heterogeneity is hard to tackle. There is a difference in drugs used and timings of intervention. You can see the first project progress here. We have completed these, and we have submitted our paper to a prestigious journal, which is Breast Cancer Research and Treatment, and we hope to hear from them very soon. Let's move on to our second project, which is comparing the efficacy and safety of different techniques in reducing donor site morbidity after latissimus dorsi muscle harvest. The muscle latissimus dorsi is a widely used flap for reconstruction in plastic surgery operations. It can be done in an immediate or delayed reconstruction, and most commonly it is used after or with breast cancer surgery. Unfortunately, donor site morbidities such as seroma formation can be very high, almost reaching 80% in the literature. This can cause patient discomfort, wound complications, or even a danger of skin flap necrosis. The strategies have tried for this procedure is quilting sutures and fibrin sealants that are studied extensively in the literature. So our aim is to find the best technique or the combination of this technique that reduces donor site morbidity the most. With our clinical question, we also use the PICO framework, which technique or combination reduces donor site morbidity the most in patients undergoing latissimus dorsi muscle harvest. You can see the different interventions here: quilting sutures alone, quilting sutures or fibrin sealants combined, or fibrin glues alone. And our hypothesis is there is a difference in efficacy, and the combination can be synergistic. With the clinical implication, we want to contribute to the guidelines regarding latissimus dorsi muscle harvest. Our search key consisting of two domains again. First one focuses on the latissimus dorsi, and the second one on the different interventions. We have searched in 5 databases, and you can see the hits below. We have started with around 2,000 articles, and we included 26 articles altogether. Here is the second project progress. We have finished data extraction, we have done the risk of bias analysis, and results should come in shortly, and we'll be excited to present those next time. And when we finish the manuscript, we want to publish this in a D1 journal, Plastic and Reconstructive Surgery. So in summary, we have 2 ongoing projects. First one focuses on seroma formation after mastectomies. This is already submitted, and we looking forward to hear about the journal. And the second project, which is the donor site morbidities and latissimus dorsi muscle harvest, we want to submit this in the November of 2025. And I want to end my presentation with a quote from Oscar Wilde: "I can resist anything except temptation." Thank you for your attention.
Congratulations for a very interesting. I am a kidney transplant surgeon, but when I was young, I assisted many mastectomy, and if I good remember, we don't use in Szeged this corticosteroid or steroid treatment. And I have a question that it's how many days use this steroid and how many milligrams?
So just to be clear, we don't use that either yet.
Mm-hmm.
Maybe this study will change it. These glucocorticoids can be done preoperatively. Then it's a...
And before the mastectomy started?
Then, yeah, so one of the options is before the mastectomy with one intravenous dose, so a bolus of
intravenous dose?
Yes.
It's very important. Because in the transplant patients, we use first step intravenous dose and then coming in pills. Yeah, so in the studies that we have included, preoperative is with the 80 milligrams of intravenous dose, and the other method is post-operatively, that's injected directly into the cavity. The suction drains are clamped, and it's like a 120 or 125 milligrams of steroid into the cavity. The drains are clamped for a couple of hours and they are released. So these are the different methods. Based on the subgroup analysis that were not significant, preoperative is better and more useful than the postoperative method. And one more question, it's very interesting. That's the steroid dose, the one daily dose, just the morning, for example? And maybe after the operations, 3 days, it's cut the daily dose or just stopped?
It's just one time, so one injection.
Just one injection.
Just one injection, yeah, because we don't want to make the patients immunosuppressant. So it's just one dose that.
And after the mastectomy, 2 drainage used or 1?
Good question. In most of the studies, only one drain, but in some studies, 2 suction drains were used. Of course, if there was a axillary surgery done, then 2 drains. And also these were measured, and because of the time I couldn't include these, but
2 drainage used if you make axillary block dissection, mastectomy and yes. Okay.
But sometimes the articles are not really clear on which.
It's very different, I know.
Yes, yes. Okay. So, but the drainage volumes were more than 300 milliliters lower, and
you can remove the drainage.
And the drain removal days were more than 3 days earlier with the glucocorticoid groups. So these are also benefits.
Okay, thank you.